Good afternoon, everybody. I'm pleased to see you on our small webinar. Before we start, let me introduce myself. I'm Konstantin Kostura. I am restorative dentist, work in Kyiv. It's in Ukraine, in the Dubnova's dental clinic. Generally, I plan the treatment plannings, I plan the implant placement, but personally, I don't place. In our team, we have a few great periodontists and surgeons that actually are doing that, and I enjoy working in team because it allows us to get a better result. So the Bio3 implants asked me to talk about the emergence profile, about the soft tissues around implants. I was deeply in this team as much as I work a lot with patients, and their expectations are growing higher and higher. So personally, I had not just only the opportunity, but the need to deeply explore this team. So generally, it will be the prosthodontist or patient-based view. We will talk about how to give our patients the best result we can in a prosthodontist perspective. So let's start. Usually, I start with this slide, one of my favorite slides. For me, it's the main part of dentistry in general. The biology has no sponsors. We work with a live organism. It has its own physiology, its own laws that it works. And we must understand them. We must to feel them maximally. We must to work in a way that actually our organism works. So whenever we try to overcome the biological laws, we gain the failures. And I should say that from the very beginning of implant dentistry, it was like in the middle of the previous century, the whole implant dentistry was focused on the bone biology. And that was not bad, just it can be easily explained by the fact that the contemporary implant dentistry begins from the osseointegration. And as far as it was opened, 90% of articles from the 1950 to 1990 were focused on the bone biology, how to not overheat it, not to overcompress, how better to create that, what type of implant surface do we need to have better and faster osseointegration, how much time does it take, and what conditions can support or will give us some failures in it. But as we see from the literature, there were a lot of biological failures. First of all, they were they were attributed to the soft tissues around the implants. Plenty of recessions, plenty of peri-implant disease that actually were the problems with the soft tissues. We didn't know how that worked. We made mistakes, and actually, the small internal, the study that was originally published in 2000, the time when the tissue biology was in a better place than 10 years before that, they showed that 80% of implants have recessions, with the mean depth like nearly close to 1 millimeter. They also noticed that the half of recessions occurred after 1 month and the 90% after 3 months. Generally, we had the stable tissues after 9 months. And what should we understand? That 80% is kind of a lot, especially if we work in an aesthetically demanding space like in the frontal upper teeth. And generally, for today, personally, my patients have huge expectations around it, and it takes a lot of time to explain the conditions that they have, and to explain my ability and my surgeon's ability to create them the aesthetics that they want. And primarily, we need to understand the function of the gingiva, of the tissues that we have in our mouth, and first of all, we need to understand that gingiva and peri-implant tissues are all the ectodermal tissues, and generally the role of ectodermal tissues in our body is protection. their primary function is protection. Whenever we should understand that the role of the soft tissues around our implant is protection. They should protect the implant that's beneath it. And first of all, we should understand the anatomy, the organ that we work with. First of all, we need to talk about such parameters, biologic width. Actually, biologic width was introduced in 1960 by Grigulio and co-authors. They had a cadaveral study, and they noticed that everyone has some apparatus that allows the connection, the apparatus that is situated over the bone, and the primary function of it is to protect the underlying bone. They call it biologic width. Actually, it consists of three parts: persistent connective tissue, junctional epithelium, and sulcular depth. In mean, they have like 3 millimeters volume, but it has in 90s, if I'm not mistaken, the Watzek made further cadaver studies, and they noticed that this parameter has huge deviation, like from 0.75 millimeters to 7 millimeters in some patients. And that's the first space we need to understand. So we also need to talk about these connective tissues, to study them, to understand how do they work. First of all, the junctional epithelium, it's actually the most coronal part that we have. The periimplant mucosa surrounding the successfully also integrated implants in many ways is analogous to the tissue surrounding natural dentition. The lamina propria of epithelium extends from the alveolar bone coronally and actually is covered by keratinized oral epithelium. In healthy situation, it forms the sulcus lined by sulcular epithelium, and actually it helps to create the continuous epithelial cover in our oral cavity. Of the tissues in contact with the implant, the junctional epithelium is the one that most closely matches to the structures around the tooth. It forms an epithelial sleeve around the tooth collar or around the implant abutment, and actually it's located in the strategically important points. So that's the first line, our protection from the bacteria and their byproducts. But despite these similarities, implants have something different. And when we are talking about connective tissues around the teeth, we know that there are Sharpei fibers. They extend from the cementum in perpendicular way to the surrounding tissues. The connective tissue forms a barrier that's inhibiting the further downgrowth of oral epithelium. And actually we need to say that the evolution of God, in terms of what we believe in, delivered a remarkably good solution for the attachment and protection. The way how it looks around the teeth, it's actually the perfect architecture, and everyone who is somehow connected to the implant dentistry wishes to have so good connection of our peri-implant tissues to the implant. But despite of it, reality is unfortunately quite different. Functionally oriented collagenous fibers adhering to the surface are actually not available. There were some studies that tried to cover our abutments with different types of treatment, but as far as we got the connective tissue connection to them, even faster we get the bacteria growth over that. So the interface between the connective tissue and the implant surface looks, at least at the small magnifications, perfectly smooth. That means that the connective tissue is adapted only to the abutment surface, and actually it cannot provide the surface adherence for the junctional epithelium. Thus, the sealing of the peri-implant mucosa and protection of underlying soft tissues are based on the junctional epithelium only, which makes it's a more fragile connection than our periodontal. But surely we have some structural stability. We see a lot of implants for today that are 10, 20, maybe some of them are 30 years old, and they're still in a good position. Around them we see good pre-implant tissues. So structurally, the most important element providing the stability of the gingiva around natural teeth are dense collagenous fibers, P fibers. The most important fibers for stability and for long-term prognosis are functionally oriented fibers that actually create some kind of O-ring. You see on the slide by Dr. Peter Schubach, how does it look like? And we understand that my primary ability as a prosthodontist and your primary ability as implantologist or prosthodontist or to create such emergence profile that will help our implant successfully to last long. We need to protect it. So these collagenous fibers form the O-ring, and in absence of sharp-based fibers, it's actually the best possible option for us. But thus we need to understand how to create that. And of course, there are some factors that affect the pre-implant soft tissues. Mission and Wines divided them on two parts: the external factors and the internal factors. The external factors, first of them is the patient age and overall health. We all understand how the older patients get, the harder the wounds heal. It takes more time, and overall health generally it implies the whole treatment. It affects the whole treatment for us. Oral cavity is one more time. I will say that oral cavity is the part of big organism, and as much as we have problems, some somatic problems, they will have impact on our oral cavity and especially on our peri-implant tissues. The second part is the presence of keratinized gingiva. We have plenty of studies in 90s of how this 1.5 millimeter of keratinized tissues affect the prosthetic implants. Today we know that even on our natural teeth we have some problems with the prosthetics on them if there are no keratinized tissues. We know that in absence of keratinized tissues, sometimes even orthodontic treatments is contraindicated. That actually explains the huge popularity of connective tissue grafts, free gingival grafts that allow to create more and more keratinized gingiva. And the absence of keratinized gingiva usually ends up in big recessions around implants and sometimes even around teeth. And the same for implants and the same for teeth. The third point is the depth of vestibule. If we don't have vestibule, if our soft tissues retracts with our cheek or with our lip, it's definitely the factor that compromises the stability of our peri-implant soft tissues. And in our early implant cases, we've seen a lot of this, that especially in an older patients when we don't have the vestibule, actually we don't have not only the vestibule but the alveolar bone. We've seen a lot of peri-implant recessions, and as we know, they are more that's harder to treat them than the recessions on the natural teeth. The fourth point is overall periodontal health. We have a quite good understanding of how general periodontitis affects the teeth and the implants. We know that the patients with chronic or aggressive periodontitis in long term that have no ability to keep it in the normal state, that generally the implants are compromised in them. We know that in 10 years there are nearly 40% failure in the patients with aggressive periodontitis. And actually today it's one of the most popular theme on different peri-implant and implant and periodontal congresses. So the next part is internal factors. The first of them is smoking, and nothing new for us. We know how smoking affects the patient's hygiene, the patient's ability to clean, and the wound healing. We divide them in aggressive and normal smokers. But actually, the same as for our general periodontal treatment, it works the same for peri-implant soft tissues healing. The second part is personal hygiene. For us, that means that if patient is not able to keep the hygiene in normal state, if they don't able to clean, whether they don't understand the need of that, or they can do that due to some obstacles. It's actually, for today in our practice, it's contraindication for the implant placement. First of all, our professional legacy is to explain our patient, first of all, how important is it to clean the teeth, and the second one, to teach them how to do it properly. In our team, we have a hygienist and periodontist, but actually a lot of time even I explain the patient how to keep their teeth, their implants, their prosthetics in a clean state. And in long-term prognosis, it has a huge impact factor. As far as personal hygiene has impact on overall periodontal health, we can understand how it works. The third part is the ability of soft tissues to heal. If we don't give the patient ability to heal after our plaintive implant surgeries, we have some continuous trauma, or the patient has some bad habits, the implants will fail. First the soft tissues will fail, and then the implants will fail. We must avoid that. Fourth part is the preservation of the biologic width, and actually it can be divided in two parts: the preservation of the biologic width on the natural teeth, because if we have invasion in biologic width in the teeth close to our implant, there actually is an inflammation, and often there is also an infection. So it will affect our implant. The second, about our implants, we need to understand how far is the bone from our implant. We need to understand that in any way, despite of all our tries and techniques, the biologic width will be created around our chew collar. Actually, this point was the first point that led us to platform switching, like from changing the place of biologic width formation from the vertical level to the horizontal level. And the fifth point that is actually the most important for me as a prosthodontist is the correct implant positioning. When we talk about implant positioning, we have a very easy rule, and usually I use it a lot when I'm planning the implant placement. The 2B3D rule. 2B stands for 2 millimeters buccal bone that we need, and 3D stands for 3 millimeters depth from the gingival zenith. In original study, it was called from the cement malleable junction. But as much as we work with patients involved in periodontitis that already have recessions, we need to understand that we should have 3 millimeters deeper from the, not from the cement malleable junction, but from the zenith. And I want to show you a case. This case is one patient. She had 2 implants on the lower jaw. The one implant was placed during the orthodontic treatment. The second one was placed after the orthodontic treatment. So first of all, we see the implant that was placed after the orthodontic treatment. Actually, on the left, you can see the peri-implant tissues that are already condensed, and we are just ready to place the implant crown that you see on the right, we see smooth emergence profile. We see the ability of our patient to clean it. We see that the soft tissues are condensed enough, and they look. First of all, they look healthy. They are not inflamed. We see a lot of keratinized tissues around it. We see actually, I see that is the way that we need to have in order to be sure in long-lasting prognosis. How do I have that? On the stone cast model, we see that the implant is placed 3 millimeters deeper, and that actually allowed us to create this smooth emergence profile. And the first thing we need to understand, the patient needs to clean it. And with these kind of prosthetics, I'm sure that the patient will have the ability to clean it. Contrary, on the other side, we see a very steep emergence profile. It's almost 90 degrees. And we see that we see a lot of soft tissues, and we see that implant is quite close to the beginning of our crown. Nevertheless, I have 3 millimeters of tissues over the implant. That's enough in connection to the incavitous and Puccio study. Also, as far as it's premolar, I understand, I explained the patient how she needs to clean that, and if it is premolar, it's reachable. The cleans of these teeth is reachable. Why do we have that? We see that the implant placed on the level of the gingival zenith. If it was the molar, I won't. It will be really hard for me to do final prosthetics that will long last. And generally, in such cases, if we do not do this 3 millimeter deeping, we unfortunately will have. In our practice, we try to extract this implant and place another one. Only the replantation is the only way to place the implant deeper, because in such cases we have compromised aesthetics, compromised hygiene, and the only rescue for us was that it's not the aesthetic zone, it's the fifth tooth on the mandibula, on the lower jaw, and it's premolar. It's not that wide. So the patient has the ability to clean it easily. About to be rule, it's all about the blood supply of marginal gingiva. What comes to our natural teeth, we have 4 ways to supply them. The first is from the periodontal ligament to the marginal gingiva. The second one from the bone marrow to the periodontal ligament, and once again from the periodontal ligament to the marginal gingiva. The third one is the cortical bone, and fourth is apically placed gingiva. As far as we place implants, we don't have the periodontal ligament around them. We must understand that, and if we won't have the 2 millimeters thick bone, the marginal gingiva won't be supplied enough with blood, and actually it ends up in recessions, in small necrosis. Mucosa actually had few studies about that, and for this one it was a histologic comparison of the biologic width around teeth and implants. It was a microvascular electronic microscopy, and actually it showed that whenever we don't have these 2 millimeters in human, we don't have enough blood to supply. So in cases where we have the patients that have multiple factors that contraindicate implant placement, that don't allow us to create natural teeth, create natural emergence profiles, like in these patients, we after two-stage implant surgery and additional connective tissue graft, that was the old tissues that we gained. Both grafts been undergone the necrosis in terms of bad hygiene and smoking. So before temporary crown placing, I've seen this. I've seen the probing around implants like 6 to 9 millimeters in different parts. So That's the reason for the implant extraction. The patient didn't want to have personal hygiene in normal state, but he understood the risks, and we gained the result that actually seen in such kind of situations. The implant failed. Okay, so not only the function that we need to understand, we also need to understand the aesthetic, as far as our patients are more and more demanding in day by day. The Busser and Belzer suggest us to use pink and white aesthetic scores to score our restorations, the soft tissues, and actually how our restorations look. They suggest to score them from 0 to 2, like 0 is the absence of this point, and 2 is maximal point. For the white aesthetic score, we have 5 points: tooth form, tooth volume, tooth color, texture, and translucency, and some kind of characterizations. For our gingiva or pink aesthetic score, we have mesial papilla, distal papilla, gingiva curvature, the high of the free gingival margin, and the lute projection, or the volume of soft tissues around our implant, in the region where the implant is placed. So how it helps us? As far as we are on the stage of our temporary restoration, we can stop, if we want, make photo or just fill the chart for better understanding what do we have originally in our oral cavity, and what do we need to have, and what do we have with our temporary restorations. In case it helps a lot for me to talk with my periodontist when we have, and my dental technician, when around implants, to say truly, often we don't have the real papillas. They're kind of they're called fake papillas, no, not the true papillas. They are not that big, and we know that on the two neighboring implants it's hard to create the natural emergence profile. So so we need, in these cases, somehow to mimic that, whether we use the pink porcelain or we will change the emergence profile on natural teeth. So the next thing we should talk about is the soft tissue wound healing. And I won't stop a lot on this, because actually it is perfectly described by Professor Sculian in his article in Journal of Clinical Periodontology in 2014. In brief, we have 4 phases of soft tissue healing. The first phase is hemostatic. Actually, we overgone these 4 phases whenever we do any kind of implant treatment, from the first blade incision to our final placement of abutment or of our crown, when we have the bleaching of our tissue. Actually, it's the hemostatic phase. It lasts not that long, like nearly an hour. And the second phase is the inflammatory phase. It lasts from first day to the 7th day. I will show you on the next slide how it looks like in oral cavity. In this phase, we have the blood clot that was formed on the hemostatic phase, changed by inflammatory tissues, the granulation tissues. And on the 7th day begins the phase of new tissue formation. It helps from the 7th to the 14th day. And after 14th day, we generally have the tissues. How do they look like? Closely, how do they look like? Will look like in the future. The 4th phase is remodeling phase. It's the longest one. It takes nearly 6 to 8 months. And actually, the presence of this phase explains us why do we have some kind of different soft tissues level on our recalls. For example, we see a lot of soft tissues grows coronally around our zirconia dioxide abutments that are perfectly smooth. So how does it look like? On this slide you see the day 0 with a blood clot on the histological section. On the day 7 it's replaced by inflammatory tissues. The wound area is already bordered with a thin layer of epithelial cells. And on day number 14 you see a short junctional epithelium formed in the place where the inflammatory cells were. Actually, that explains us why do we need this 14 days delay between our temporary crown modifications. So we are ready to talk about emergence profile. First of all, the term emergence profile was introduced in 1977 by Stein and Kubata. They called the emergence profile the way how tooth rises from gingiva to the contact point. Next, there were the photographic study observation conducted by Kroll in 90s. He noticed that generally emergence profile is smooth and it has steep lines, and almost in all patients it has the straight, it's straight if they observe that. In 1989 there was also one study by Wheeler and he said that the emergence profile generally is not that steep. In some cases it might have some convexities. But actually, what we should know for that, in 1971, the Birch conducted 10 rules for developing the crown contours in restorations, and actually that's the way how we need to understand the emergence profile for today. Originally, it's very close to the thing that was published by Kroll. We shouldn't have any convexities, concavities, because they are first way to the periodontitis around implants. For today, the glossary of prosthodontic terms give us such explanation. The emergence profile is the contour of a tooth or restoration, such as crown or natural tooth or dental implant abutment, as it relates to the adjacent teeth. So why do we need to understand that? Actually, we need to create the prosthodontic contour. We need to create the conditions for creating such restoration contours that will correspond to the contours of the patient's natural teeth. We must make such restorations that look the most closely like natural teeth. And actually, as we see on this case, it's not only prosthodontist perspective, it's the team's perspective, beginning from the patients, that should treat his teeth in a normal way, that should have perfect hygiene for our implant for long-term result, that should maintain the periodontal health. That's the obligation of dental technician, of prosthodontist, of periodontist, that need to create conditions and actually the final restoration to make it in the such way it will correspond to the contours of patient natural teeth. Next question I was asking myself when I began the way of the implant prosthetics is how to fit the crown to the implant. Actually, the most absent teeth in the oral cavity is the first molar, and it's quite a big one. It has from 12 to 22 millimeters in vestibular oral, and often we see the patients that generally don't have that a lot of bone in this space, but they have absent first mandibular molar, and after some surgeries we place the implant that often is like 5 millimeters in wide, but still we need to place a crown that is like 2 centimeters wide. How do we do that? How do we fit it there? How do we create the profile that can be cleansed? And actually, why do we need to take a lot of time, our time, our patient's time to create the beautiful emergent profiles, especially on the posterior teeth? We see on this slide that actually took me 3 visits to create these soft tissues. It took like 2 months of time. It was huge work, but at the point we are placing the final restoration, I am sure that it will last long. I'm sure it won't have kind of regular problems. I'm sure that the patient knows how to clean that, because we had a lot of discussions with him on how to clean the teeth around implants, and actually you see that there are still some problems, like on the posterior region. On the left side, the gingiva is a little bit overcompressed in the papilla because of the foot were trapped there. But as I see this patient on recalls, and this was done already a year ago. The soft tissues are in a perfect state. He knows how to clean that. He does that every day because he knows, he understands all the paths that we've gone together to get those restorations in there. Also, we have the study by Furz and co-authors about the aesthetic outcome of implants supported by crowns with or without peri-implant conditioning. And they had two groups in which one was with temporary crown, the one was already with final restorations. And they scored the pink aesthetic, white aesthetic score, the marginal bone loss, and they scored them for 1 year. What have they noticed? First of all, the marginal bone loss in both groups had pretty much the same numbers in 1 year, and I'm pretty sure it works how it looks like, because from the study, once again with Piusius and Linkevičius, and the whole zero bone loss concept, we know that the more role plays the height of the soft tissues covering our implant. But the pink and white aesthetic scores were better in a group with temporary crown. So what have they noticed? They have noticed that implants have more recessions when at the final stage we place the final crown without soft tissue conditioning. And 90% of my cases are actually undergoing through the temporary stage. Especially in the posterior region, but sometimes we have conditions the patient doesn't have enough time, or there are some life obstacles that doesn't allows us to make a temporary crown. Like in this case, we had seamless lifting procedure, and the patient was in our country for only 6 weeks after the implant was already also integrated, so we didn't have enough time to place the temporary crown, and we suggested to place the final crown. As far as I don't use a blade to help the soft tissues to undergo the implant placement, and this is a conical system, so we understand that in internal conical systems, the soft tissues do not allow us to place the implant deep enough. As you see on these slides, the soft tissue former is not that wide as the crown is. So often I place implants and I give my patients like 2 to 3 weeks, and actually it was a screw retained crown, and I cover them with the temporary filling. And after 3 weeks, in this case, I have the crown was loose. Sometimes I see that, and mostly I see that in the patients with final prosthetics right after the gingival former. Also, we see that the patient doesn't understand how he needs to clean his teeth. We see the second molar with a lot of plaque on it. We see beautifully formed the soft tissues around the zirconia. They form in the best way, because the zirconia is the material that it's most prone to epithelial growth around it. And also we see how the smoking affects the teeth. The brown color on the implant is not the one the dental technician made for me. Actually, these slides explain two things. First of all, the tissues need to be conditioned gently. We need to take more time with our patients. We need to understand that on conical systems we might have this screw loosening because that's too much pressure for one time. And the second one, we must educate our patients. This patient was very impressed by these photos I showed him, and I hope he changed his habits of his hygiene. So for today we have a lot of concepts on how to create the emergence profile, how to condense the soft tissues, but I will actually stop only on 4 of them. The first one is cervical contouring concepts that actually it was suggested by Nitz and Bichachi in 1996. What's the whole idea? The whole idea is that we have two-stage surgery. Generally, so nevertheless, we even can have one-stage surgery, but we have gingival former, and only after the implant is healed, only after the soft tissues are healed around the implant, we take an impression, and our dental technician makes actually a temporary crown for us. Cervical contouring concept stands for this dental technician cutting off the gips or gingival mask on the model and positions, first of all, the zenith and gingival level on the level that he sees he needs to, and actually we are making as much as possible the final emergence profile on this. But we have two requirements. The first is the presence of soft tissue for modeling. If we don't have soft tissues, like in the patient I showed you earlier with insufficient soft tissues, we won't be able to create anything. It's not the prosthodontist perspective, actually, it's the periodontist or the surgeon's perspective to create the soft tissues for modeling. And the second requirement is the gradual creation of emergence profile. As I've shown you on the last patients, it's sometimes, especially on the molars, it's too much. We have too much risks to overcompress the gingiva, especially if the compression is actually a hemostatic phase. If the hemostasis will be too long, the necrosis will compound. The second thing we need to understand about the gradual creation of the profile is the multiple abutment reconnection. There are studies by Ampersson and Linde in 1997 that shows that normally we have 5 to 7 disconnection of our superstructure. And this study shows us that the more disconnections we have, the more bone reacts. They've seen the more marginal bone loss around the implants with multiple reconnections, especially in case where we have more than 10 reconnections. But this study was never conducted on a human, and as long as personally, I do a lot of reconnections, and I don't see any increase in marginal bone loss growth. What do I see is that the conditioning of soft tissues actually enhances a lot the predictability of my treatment and enhances a lot the soft tissues level. The next concept that we see is the concave transmucosal abutment. Actually, it was introduced in 2007 by Rompen, and it's actually for the immediate restorations. What does it stand for? The Rompen suggests that we should have that subgingival contour in all immediate cases should be at least flat or better concave. Why do we have to do that? Because we have three factors that ensure the good stability of tissues in such cases. The first one is macro groove. The macro groove is marked by letter A. You see that on the right image. What we have? We have the more tissues to grow in, and actually in time when we will place the final prosthetic, we can push them marginally, push them vestibularly. The second part is concave profile. Actually, when we have concave profile on temporary restorations, we also have we have blood clots there, and we have more tissues to grow in. And also Rompen shows that there's a better formation of fibrous ring, also known as O-ring. And for today, I see a lot of information about one implant, one abutment for life use. And it's great when we are talking about multi-units, but there are some contraindications when we talk about the zirconia abutments for single tooth restorations. The study of influence of the emergence profile on the amount of undetected cement excess was conducted in 2007 by Sancho Cades in clinical oral implant research. Often when we do have an immediate case, we especially in this aesthetic region, we don't always have the ability to make a screw retained crown, and that's kind of normal. We have in my practice, we have a few of cement retained crowns, but still it's a good option. And what we need to understand, in case if we are placing one abutment for life, and if it should be concave, if it is concave, this study shows us that we have a lot of more cement remnants in the group with concave profile. On every type of our cemented reconstructions, we should make a concave profile, because actually we know from the study of Linkavicius about the periimplantitis that the cement excess is one of the major points for periimplantitis for today. Also, we know that even experienced prosthodontists are not always available to clean the whole cement beneath the abutment level, especially if marginal level is placed more than ½ millimeter beneath the pre-gingival margin. So the next concept is actually one of my favorite. It's critical subcritical concept. It was introduced by Gonzalez Martin in like 8 years ago. What he suggests? He suggests that we have two counters. The critical counter is located 1 millimeter beneath our gingival margin, and actually it explains us where the gingival margin will be placed. The subcritical contour is the whole contour from our critical level to our implant region. The critical contour allows us to push our teeth to create more tissues if we use concave profile, or to push them if we use convex or flat contour. So how does it works? This patient had an implant placed in a left central incisor. The temporary crown was made Nitsum-Chachu cervical contouring concept, and actually that is how our patient looks in 3 weeks after placing of temporary crown. When I removed the crown, we see the tissues are forming pretty well, but still I don't have enough space, enough gingiva vestibulary. I want to push that a little, and I have the open embrasure in the papillus region. So what do? I mark the pencil, the gingival level, and I modify the emergence profile. First of all, I modified the subcritical contour to push the tissues more vestibulary, and I did very little placement of composite, but actually I can do a lot more, especially in patients with thick biotype. Also, I placed my critical contour a little bit apically to create a more aesthetically pleasant emergence profile, to place the gingival level on like it's placed on the neighboring tooth. And actually that's how it looks like immediately after placement. We see the tissue blanching. Actually in the literature there are no information about why do we need to wait 15 minutes to overcome blanching. It was just a proposition of one of authors. So we must be clear enough to not to overpress our soft tissues, but we can be sure that the 15 minutes is not the stop for us. We can push them more. So that's how it looks like, and that how the soft tissues look in 3 weeks. What do we have? We see the soft tissue thickening. Actually, that's one of the most beautiful part of this concept, subcritical concept. We see the soft tissue thickening, we see the modeling, we see that our gingival margin level has been displaced where I want to see that. But still, it will take a little time. We know that remodeling phase takes a little longer, and as far as my patient for now has some financial problems, we need to wait, and that's a great opportunity for us to condense the soft tissues in the best way that can be seen. The next case I want to show you is actually the Oscar Gonzalez-Martin case that he often shows, and it shows in the most beautiful way how this concept works. What do we see on this slide? We see a temporary crown, we see that we don't have enough tissues vestibularly, and the main suggestions that all of surgeons give to me is, you should just place connective tissue grafts in there. But we see enough tissues there. We have really enough tissues, but they are not trained enough, they are not compressed enough vestibularly. So what our author did, he did like 5 to 7 modifyings of his temporary crown, and that's the profile that he get. He get 100% natural, 100% stable soft tissues before he's going to place his final restoration. It's not only beautiful in terms of aesthetics, it's beautiful in terms of function. It's beautiful because you see the pupillas here, they are the same as around the natural teeth. You see the marginal curvature, it's the maximum point in white aesthetic score. It beautifully integrates in the smile of the patients, and for me it's the way how I want to be treated, and that's the way how I want to treat my patients. The last one concept for today is dynamic compression technique. It was suggested by Witteneben in 2013 in Journal of Periodontics and Restorative Dentistry. So what do they suggest? They suggest to place, first of all, our counter-temporary restoration, to compress the soft tissues to the level where we need them, and on the next stages we should thicken the soft tissues. Originally the author suggests not even to remove, if it's possible, not even to remove our temporary restorations, but modify it intraorally, so we will have the blood clot formation in the space where we overcompressed. And on the phase of stabilization, which actually takes time with the permanent restoration, the soft tissues will form. I tried to make to work in this technique. Actually, it works too, but I'm not really that type of guy. But you should know that, and you should use that in cases where you want, because actually that's a beautiful technique. It's not that controllable as the technique I introduced as the previous technique, but still it works beautifully. So at least we are ready to talk about the BioLINE suprastructures. The BioTree implants have these kind of suprastructures, and they beautifully work in some cases. I want to show you how do they work. First of all, what's BioLINE? That's two types of superstructures. That's anatomical gingival formers and anatomical abutments. Why do I call them anatomical? Because on their slide they are the same as the natural teeth. We know that the emergence profile is of our central incisors, of our canines, is never round, but my dental technicians always bring me the round, the crown with round emergence profile, and that's hard to get. First of all, it's hard to get natural appearance with round emergence profile in the teeth that are never round, and the second one, it's hard to create functionally stable. So BioLINE gives us really great possibility to create a beautiful emergence profile. So advantages and conveniences of the system. First of all, the anatomic shape of the gingival former allows one to immediately create a natural emergence profile of permanent restoration. So if it's one-stage surgery, we place the implant and we already can place the gingival former that has first of all, it has anatomically correct profile. The second, it can be modified, but for the permanent restoration, it's already convex. So the tissues are forming around it in the best beautiful way. The second part, it's titanium, grade 5 titanium, so the tissues heal in a beautiful way around it. The second advantage for me, it's a great advantage, is that in the case of immediate implantation, the gingival former seals the cavity without needing to be topped up with the composite. Personally, I hate to place a composite in a wound. I'm never sure it's smooth enough. I don't think the patient can keep it smooth enough for a long time. And in immediate cases, patients have to hold these kind of restorations for at least for 2 months. Yeah, but we need to understand that classically in an immediate cases the socket should be sealed maximally. With BioLINE it's quite easy. You just place the correct shape of gingival former. Like in this case, we had 2 broken premolars on the upper jaw. We didn't want to go on the partial extraction therapy because they were endodontically treatment, and we are not sure in such situations, especially the patient had enough buccal bone there, and we placed implants. We just choose 2 gingival formers that fulfilled the socket that we have and filled them in, and actually that works a lot. In example, the next case, the extraction of fractured upper premolar, we are placing the BioLINE abutment. Also in this case we placed free subepithelial graft, connectical subepithelial graft, and in 3 months we have beautiful natural looking soft tissues. We have the profile that actually looks like on the natural teeth, and in this case I used the BioLINE abutment as transfer for the closed tray. Actually it's one of possibility we can use the BioLINE suprastructures as, and in 3 months we see the beautiful emergence profile, beautiful soft tissues in place. We see the profile as it looks like a neighboring natural teeth. We see enough buccal soft tissues, we see that they are well keratinized, we see that they're really smooth. And actually in this case I used the BioLINE superstructure, BioLINE abutment as a transfer for closed tray. That's one of the opinions. It is screwed in, we don't see any blanching, and the dental technician, dental lab creates the form that we need, and actually it was this cementable crown. It was the metal ceramics. The patient is happy with it. We see beautiful soft tissues, we see beautiful emergence profile, and I'm sure it will stand for ages in this patient. The third part is that we minimize the risks of inflammation of peri-implant mucosa with squashing the gingiva, because actually, as we see on this picture, the shape of the superstructure and the shape of abutments are nearly the same. And we actually see how them look like. Once again, I will tell you that we can use the abutments as transfers for the closed tray. It's not the perfect solution, but it works good enough on the single restorations when we have the ability to take an easy impression. Also on this slide you can see how does that looks like when we use the standard gingival former, and whenever we actually that's the case when first I used the gingival former, because we didn't had a BioLINE for that time in clinic, but after that we placed the BioLINE gingival former, and you see how it pushes the soft tissues in the buccally. It allows the restorations to look more natural. Also, we use them in multiple units cases, like in this one. This was a one-stage surgery. We placed implants. The periodontist with me, we choose the BioLINE superstructure that we want, and in this case we will work on the individual abutments, but the BioLINE gingival formers helped us a lot to create emergence profile, actually in no time, only with a surgical procedure. So, take-home message. First of all, the peri-implant soft tissues they look quite the same, but they are not the same as the periodontal, and we must understand that. We must keep in mind that implants, in terms of inflammation, like peri-implantitis, they are a little bit more fragile. They are more prone to recessions, and that's harder to clean them. That's harder to make some implant coverages like periodontal growths or subepithelial growths. But the biology is pretty the same. Their main function still is the protection. The third is the formation. Is that the formation of emergence profile allows us to create the more stable tissue. As we see in that study with pink aesthetic, white aesthetic scar. The only way to make predictable restoration is to make a temporary restoration, after it to go for a permanent restoration. The fourth point is there no prosthetic way to create gingiva. It's a periodontist function. We should ask if we do the perio, we should make enough soft tissues on a surgery phase. There are no way to create soft tissue with a prosthetic reason. We can push that, we can modify that, we can allow the blood clot to formate new soft tissues and push them more, but still we should have them. We should have enough of them before the prosthetic phase begins. So thank you for your attention. If you have any questions, I would be happy to answer you, whether on my email that you see on the screen or on Facebook. I will be happy to answer any question. Thank you for your attention once again. See you.